Okay,
Uh,
approved.
so, Neeraj sir, yeah.
Yes, go ahead.
So good evening to all of you in the another session of the Sexual Medicine Committee, Foxy. My dear friend, Sexual Medicine Committee is always very much famous to have a different coming with a different topic, coming with a different idea. And with the blessings of our president, Dr. Rishikesh Spicer, Vice President Dr. Asha Bakshi ma'am and the Secretary General Dr. Madhuri Patel ma'am, we are come up with this unique series, the Practicum series. This series is all about basically to have how to deal with the practical approach of dealing with the various sexual problem which we are facing in our day-to-day life. So we are today the second session of this practicum series, and the topic for today is the premature ejaculation. So we know all of you, whenever we start something new, we are always getting blessings from our senior. We are really, really very honored to have none other than but our own dynamic, charismatic president of Foxy, Dr. Rishikesh Spicer. Sir, thank you so much, sir, for giving your time and for always your blessings and your guidance. So I would like to invite you to please give your blessings and give your comment for this session. Rishikesh, sir.
Hi, Apurva. Thank you very much for inviting me. Neeraj, our dynamic
2 मिनट के लिए रुक जाओ क्योंकि
chairman of the
गैस होना भी है, फिर
Sexual
मैं
Medicine Committee of the
हाँ
Foxy. And he has also won the award this year. Congratulations to him. He has done a lot of work in the area. It's a very challenging new area. We are not, many gynecologists are not aware of it, and we need to be well tuned in this. And he has really made, and his whole team of members, nearly 30, 40 of them, including Apurva, who is our incoming chairman, very dynamic, has earned a lot of awards, and very sincere, hardworking, dedicated, it's a very good example for a lot of youngsters. You're a very good example. You and Priyankur and Rohan and all of you youngsters, they have to encourage other people as well. And Iraj is a good example of a chairman who is so dedicated. And then we have a lot of our Anita Sabarwal, I can see here, and Dr. Deepika and Dr. Mitra Saxena, our another. Anita Sabarwal is not a chairman, but she is like more than a chairman. Her work, kind of work output she has done, and I really am thankful to her, grateful to her for doing fantastic work this year. Mitra, again, a fantastic asset to the Federation, lot of work. And then Dr. Reddy and Dr. Muhammad is there, and as many others, Dr. Zeenat is there, and many others are there. I will not take much time, but this is a very important aspect of, and I think in a practice we must start focusing on other preventive things like mental health, sexual health. Ask them about violence when they're sitting in your OPD. Ask them about whether they have had a problem in their family, cancer is there or not in their immediate family. So we can offer them BRCA 1 and 2 screening as well. Target them for vaccination, HPV vaccination. So when a patient comes to you for a simple symptom in your and is waiting in your clinic, that's the time when you must, and the only way to do it is by having a relationship officer. So your secretary can't do it, your assistant doctor can't do it. You must create a new entity which should stay in your OPD, and when their patients are waiting for you, must distribute this pamphlet. Are you having sexual dysfunction? Are you having, so that you insert that idea into their mind. They don't have any information that they are having this problem. So because they don't know only, na, they don't know only. They only know how to see Shah Rukh Khan or Salman Khan or so they don't have the concept of health problem, and if they may be suffering from them, but they are not aware of it. So I think that one of the things we need to do is create the awareness amongst our patients that there are a lot of other things that if they treat, then they will, even obesity. So I wanted to do this, but I failed. As a president, I wanted to do a lot of things. One of the things I wanted to do was to, weaponize our waiting areas and to target our patients in these different alternative thought processes. But I failed in that. And maybe as I now become the past president, I will work for other presidents to, do this thing, because I also believe in what is known as leadership continuity. we need to, we know there is a tendency for leaders to pass out, phase out, but that's not good for the organization. Obviously, you have to be under the new leader. You can't be the leader all the time, but surely you can support the new leader in his implementation of his ideas, and also, encourage him to implement some ideas that are in continuity. So I feel that we must always be collective in our approach. So anyway, I'll not take much of your time. Thank you, Neeraj, for calling me here. I'm just landed in Kolkata. Wonderful. Dr. Tantia is there sitting next to me, and Dr. Suma Viswas is there. They are come to collect me, and I'm going and giving the oration now. The annual meeting is of the Bengal Society, and tomorrow I go and do my last program, and that is the most important for me when I look back. Which is the most important program in my life? The tomorrow's program, the tomorrow's Yuva Foxy is a statement for me. It is in Imphal. It has had undergone a lot of strife, but we will go. We will reach there. Even if there is we will fight the hurdles. And that is the statement. It is not the quantity which is essential. It is the quality of work which is important. And for us, that Imphal, which is our member society out of the 270, for us to go there, it is in itself first statement that we stand by each and every society, be it A society, a B society, or a C society. We love each and every society of us. All the best to all of you. Thank you.
Thank you. Thank you
Thank
so
you,
much,
sir.
sir.
Thank you so much.
Thank you so much, sir. So, after the blessings from our very dynamic and charismatic President, Dr. Rishikesh Pai, sir, now it's the time to take the blessings from the chief guest for today. And again, we are very, very honored to have you, Muhammad Samsul Ahsan, sir. Sir is an international figure. Sir is at present the president of the South Asian Society for Sexual Medicine. Sir is the member of the International Society of the Sexual Medicine and a lots of fellowship and awards in his credits. We are really lucky to have you, sir. Over to you, Samsul, sir, for your kind words and blessings.
Thank you so much. Thank you, Dr. Apurva, for a brief introduction, a nice introduction. But I am very new in this field. Our journey is almost 1.5 decade, 15 years of journey. But I can see a lot of dignitaries who have contributed in their respective field for more than 3 to 4 decades. So it was always my pleasure to be with part of the different societies where we see a lot of diversity. And sexual medicine is truly a multidisciplinary society. What we have seen that in Bangladesh, we work together with a urologist, gynecologist, psychiatrist, endocrinologist, and dermatologist. So altogether, we put up a show, and I'm pretty sure that India has got a long cherished heritage, and there are a lot of champions in the field of sexual medicine from different perspectives. So the topic premature ejaculation is the very much burning issue, and it is more prevalent in South Asia. It is said that 20 to 30% of the male have got premature ejaculation, and in 1 in 3 or 1 in 5. And also it is said that it is evident that the South Asia has got more premature ejaculation. So what we see, many of our patients who have got gynecological problems or infertility, their reason of having sexual dysfunction may be part of their partner's problem. And it is said in the Western world that 50% of the female patients have, partner's sexual dysfunction. Often as a gynecologist, we can overlook this because maybe it was in your busy time. It's very difficult to explore the male partner as well. I am pretty sure that Dr. Rahul Reddy is an eminent, sexual medicine specialist. He will touch upon this topic. And we are currently conducting a study on the quality of life, and it is pretty much affected in the patients of premature ejaculation and also the patients of VT. Hope this presentation will give us some highlight. And I am telling again, it's my very best pleasure to be here, and thanks for having me. I will learn a lot of from the senior colleagues. And the last thing is, I want to carry forward the journey because OGSB is an active part of SASEM in Bangladesh. So the Foxy, with the help of the OGS, we can put up some joint session in future meetings in Sasan. We are going to have a interim meeting in 2024. Hopefully, I will invite Dr. Neeraj Jadhav and other dignitaries to be in the sexual medicine part. So we can bring a lot of thoughts together. Thank you all, and thanks again for having me.
Thank you, sir. Definitely, we will do some joint work together. India and Bangladesh, we can have a best collaboration together.
Samsul sir, yeah, thank you so much, sir. And really, we are very delighted and we are really very excited to work with you. And because I think so, after Neeraj sir, with the guidance of Neeraj sir and all others, I am taking over the Sexual Medicine Committee in 2024 January. So the first thing is there, we don't have any research, a solid research for the Southeast Asia. So really, I want to come up with the research and with the actual data of our own peoples. What the data which have is actually the data of the Westerns. And actually, we are doing a lot of work. We are seeing a lot of patients, but unfortunately, we are not writing this. So this is one thing. And I think with the people from the Bangladesh, from Nepal, from Pakistan and Sri Lanka, we can do a wonder, and we have our own data of the Southeast Asia. So thank you so much, sir, for coming and for guiding us. And I in the future also, I will definitely take your help and your blessings and guidance, sir. Samsul sir, thank you so much.
It will be a wonderful idea. I'll be very much looking forward. Thank you so much.
Absolutely, sir. Thank you so much, sir. So after the from the chief guest, now it's I would like to invite my co-moderator Dipali Mittal ma'am to invite our very special guest for today, the guest of honor, very dear Mitra ma'am and Anita Savarman ma'am. Dipali, Dr. Dipali ma'am. Yeah.
Very good evening, everyone. And today I have the honor of inviting our guest of honor, Dr. Mitra Saxena ma'am and Dr. Anita Sabarwal ma'am. And Mitra Saxena ma'am, I'm a big fan of yours, ma'am. So we all know Dr. Mitra Saxena ma'am. She's a senior consultant in private practice in Rewari, Haryana. She's active in Foxy for last 20 years. She's past president and now patron of Rewari Obstetric and Gynecological Society. She's a convener and project director Mukti of Haryana Obs-Gynae to increase awareness about freedom from unwanted pregnancy, breast cancer awareness, and cervical cancer free India amongst doctors and women of Haryana. She is member of many societies like IMA, Foxy, IAHR, Images, NARCHI, and so on and so forth. Her main areas of interest are high-risk obstetrics, ultrasound, endoscopy, infertility, colposcopy, and contraception. And she has contributed many chapters on vacuum, operative vaginal deliveries in PG textbooks of obstetrics, Foxy, GCPR on ectopic 2020, GCPR on PPH 2022. And she's...
Fine, Dipali.
Without wasting much ado, I'll just invite Dr. Mitra Saxena ma'am for her words of wisdom.
Good evening, Dipali. It's always very flattering to know that there is somebody who is a great fan. Well, I have to give it to Foxy to give me the opportunity to work as the chairperson of Practical Obstetrics Committee, which got me to be friends with Dr. Neeraj Yadav, who is the chairperson of Sexual Medicine. And because of Dr. Neeraj, today I am here as a guest of honor. Well, friends, being a obstetrician who has been into practice in a small city over 20 years, two and a half decades, I just want to confess one thing, and that is that sexual medicine, premature ejaculation is kind of a blind spot where we obstetricians are concerned. I agree with Dr. Mahmood Hassan and Apurba and everybody that in our busy practice, we are dealing with infertility, but the assessment of a male partner begins and ends with a seminogram. A gynecologist, whether it's a female or a male, would insist on what are the do's and don'ts to, get correct report, which lab, what are the prerequisites. But are we asking them anything about their coital history? Are we interested that there is some, marital discord, which is the manifestation of a sexual dysfunction? So actually, hats off to you, Neeraj. You really, really have brought sexual medicine center stage. And Foxy, has been magnanimous, Dr. Pai and all, to give you the award as the best committee. I really, really am very appreciative of our national leadership who have thought that to give importance to a discipline which actually forms a basis of a very sound society. A sound marriage converts into a happy family, and that's the backbone of a society. And premature ejaculation or a sexual dysfunction or a female who's not satisfied and unhappy, how important it is. So first I want to give you lots of congratulations, Neeraj, and to Apurba. The benchmark is set very high. So please, you have to take it higher, and you're fortunate that Neeraj is there to hold your hand. So that is there, and Deepali and all the people who are here. And now coming to the topic today, well, I was a little bit skeptical why Neeraj has called me, but then I realized that whenever we are there as a chairperson or as a guest of honor or as a speaker, it gives us an opportunity to go into the topic ourselves. So a little bit I did background research, but more I will be happy to hear from Dr. Rahul Reddy. But fact of the matter is that obstetricians, we have forgotten that what is the male activity of, sexual activity as such, erection, penetration and ejaculation. So at the end of the day, it all becomes like a blur. So I'm sure that our speaker for today is going to make things simplified and make us understand. And basically speaking, I would say that as a busy practitioner, somewhere we lose element of empathy, where we do not give them time. It's just a little bit of time, as Dr. Rishikesh Pai said. We give them a little bit of time and their whole story comes out. Of course, what are the medical treatments? What are the psychological support system? Everything we will be listening from a very good speaker. We have seniors in the audience also there. And I am going to be really actively listening. And my words of wisdom is to my own self that listen to this. It will help some patient somewhere if I am attentive today. Right. Of course, we should not take everything in our hand. We should also know who's the right person, because tragically, people who have premature ejaculation, etc., they first go to the nadi where they go to that, they look at all the advertisements on the walls, etc., which give all the wrong directions. So, of course, Viagra is a part of treatment, but I think, our speaker will educate us how it is abused in our people. So misinformation, lack of information, I think we really cannot afford in today's practice to come out as with a blind spot. So over to Dr. Anita for her share, and thank you, Dr. Neeraj, Apurba, and everybody. Dr. Mohammed, it's a pleasure to be amongst all of you. And of course, Dr. Rishikesh Pai, I think he has run a very fast race. We have all tried to match his speed and falling short somewhere. Okay, all the best, friends. Thank you so much.
Thank you, ma'am, for the words of wisdom. And may I now invite Dr. Anita Sabarwal, ma'am, our guest of honor, for her blessings. Ma'am is a President FOGSD, Chairperson Public Awareness Committee of ISCCP 19 to 21, past Chairperson Adolescent Health Committee, AOGD, Executive Member of AOGD 17, 19, 20, Executive NARCHI in Delhi, Invited Member of Women's Cell of Violence Against Women, Advisor MTP Committee Foxy, Master Trainer Dheera by Foxy. She is a certified UNICEF GBV trainer and member of Safe Motherhood Committee Foxy, National Faculty with GOI, and she has many more. There is endless list. The list is endless, ma'am. May I now invite you for your blessings, ma'am?
Thank you, Dr. Dipali, for the very kind introduction. And I'm really thankful to Dr. Neeraj Yadav and, of course, Dr. Apurba, whom I really know so well. He's so grounded. And, of course, Dr. Pai, sir, as you were just mentioning, we become so close and friendly in this 1 year with Dr. Pai, and under his leadership, we have really done a lot of work. And me especially, I always say I'm the awareness doctor. I'm the awareness person. So he has given you so much opportunity to do a lot of work in awareness. So I was happy that you people invited me, but I'm really honored that you all made me guest of honor. And I was just listening to my previous guest of honor and our chief guest today, and of course our president. And it's really true, this is a very, very challenging and a very new subject. And this really needs a lot of awareness. We must generate a lot of awareness amongst the younger generation, especially during adolescence only. If we start creating awareness amongst them, so these problems really can be sorted to a great extent, because this has become a very big problem, and this is a hidden problem, because many people, they don't even want to talk about it. It's such a taboo talking about sex education anywhere. We talk about, we say in school, you talk to the adolescents, or you go to the colleges, or you talk to the families. It's a big taboo. Even when the patients come, the husband will never like to talk about it at all. Especially I see a lot of infertility patients in my clinic, because I am very much at a very ground level. And mostly I have really come across hundreds of people like this, or maybe thousands, in the last almost 39 years of my practice. So this is something very good which you people have started, and I hope it really goes on and on, like we did for the polio vaccine, and ultimately we could get rid of polio. So it should become the talk of the town, and maybe slowly and gradually, once the people are sensitized on this, they will really come out openly and talk about it. And once they talk about it, things can really be solved in a very friendly manner. So thank you so much for giving me the opportunity, and I really wish all the best to Dr. Neeraj Yadav. He's already done so much for this committee. And now Dr. Apurba, I'm very sure he's really going to take it also to greater heights. And thank you, Dipali, for the opportunity. Thank you so
Thank you,
much.
ma'am. Thank
And
you.
I want to tell you one thing. Today I have reached Kerala. I'm here at Kochi right now, and you can just have a look at my friend, my classmate, who's with me, Dr. Susan Kochi from Kerala, Kochi. So I'm going to spread this thing in Kerala also today. So I'm very happy that I'm in a very good mood today. I'm meeting her after I don't know how many years. Meeting her almost 35 years. So
Wow, that's
that's the thing.
wonderful, ma'am.
Yeah. Thank you,
Thank-
Dr. Apurba. Thank you so much.
Thank you so much. Thank you so
See
much,
you at
Mitra ma'am.
Hyderabad now.
Thank you. Yeah, absolutely, ma'am. And thank you so much, Anita ma'am. Thank you.
Yeah. Thank you.
So, after this wonderful blessings and chit chat with the seniors, now coming to the scientific session. So, the faculty for today is Dr. Rahul Reddy, sir. Again, very dynamic, very sweet, and very helpful senior of mine. Sir doesn't need any introduction, just a brief. Sir is a consultant at the microsurgical. Sir is a consultant microsurgical and andrologist and director of the Androcare Andrology Institute, Hyderabad. Sir has a lot of fellowships and award in his credit. And thank you so much, sir, for always accepting our invitation to be part of this webinar. So over to you, sir, for the topic for today.
Yeah. Thank you, Apurva, for your kind introduction. And I also thank Foxy Society for giving me this opportunity. I think as requested or as we have decided, we'll be dealing like how we dealt with our erectile dysfunction topic. We'll be dealing with practical aspects of premature ejaculation, so that any doctor who wants to treat a patient of premature ejaculation, instead of going into theory, I'll be telling about practical aspects of premature ejaculation. So practical, like our how our guest speaker said, at least 30 to 40% males, they are suffering with premature ejaculation. And this is one of the major issue in young males who marriage. In our day-to-day practice, we see many young males who are avoiding marriage only because of this. See, at least people who are having erectile dysfunction, they take PD5 inhibitors, and sometimes they can manage with PD5 inhibitors. But premature ejaculation is the one which will actually take their confidence out. So what happens is, another issue is, this is one of the reason for infertility also. If a male is having severe premature ejaculation, that means if he ejaculates before penetration, then this can lead to infertility. So in some males, this can be the main reason for infertility, and this is a vicious cycle. See, now once a male is having premature ejaculation, he will have performance anxiety, and once he have performance anxiety, and next time whenever he tries to have intercourse, sometimes even he takes sildenafil or tadalafil, because of the performance anxiety, again he'll have premature ejaculation. And if this continues, if this cycle continues, after some time, these males, they lose confidence in their sexual performance, and they stop having intercourse, or sometimes they even try not to attempt for intercourse. And this creates
Sir,
some
sorry
gap
to
between
interrupt,
the
sir.
couple.
Sir,
Uh,
your slide is not moving.
no, I'm not. This is only introduction. I'm not.
Okay. I'm
Okay.
extremely sorry, sir. Yeah.
Yes. So, yeah, really, it's not moving.
Sir, please unshare it, then please reshare, sir.
Yes.
Yeah, and please reshare it, sir. Yeah. Sir, try to move it. Yeah.
Yes.
Now it's moving. Yes, sir.
Yes. And coming to definition of premature ejaculation is male sexual dysfunction characterized by a perceived inability to control ejaculation that occurs sooner than desired or expected, either before or shortly after vaginal penetration, and causes emotional distress for patient and or his sexual partner. So coming to epidemiology, already we discussed 30 to 40% of males, they are having issues, but problem is most of the males, they get confused between erectile dysfunction and premature ejaculation. So that is the reason they start taking sildenafil and tadalafil, and even most of the physicians, they get confused because the patient himself cannot explain what exactly is happening to the doctor. Even sometimes we get confused. Sometimes second or third visit, they say, "Doctor, I'm not getting improvement," because initially they say erectile dysfunction. When we ask about their ejaculation, they say normal, but after 2-3 visits they come back and say there is no improvement. Then when we take clear history, they say erection is good, but ejaculation is quick. So that is why premature ejaculation, to differentiate between sexual dysfunction, erectile dysfunction, and premature ejaculation, we have to ask some leading questions to the patient, whether he's getting proper erection, or whether even after getting erection, if he is able to maintain the erection till he ejaculates, or he is losing erection after ejaculation. So that will differentiate between premature ejaculation and erectile dysfunction. So in premature ejaculation, we have two types of premature ejaculation. One is primary premature ejaculation, and second one is secondary premature ejaculation. Primary, we say sometimes lifelong premature ejaculation, or which is there from the beginning. And secondary premature ejaculation is also called as acquired PE. So acquired PE means people who are having normal ejaculatory control in the beginning. Later they start ejaculating prematurely. That is called acquired PE. Lifelong premature ejaculation is there from the beginning. It is there from their early marriage times, at the time when they start masturbating. Sometimes the way they start their masturbation, trying to ejaculate quickly to avoid others noticing that they are masturbating, even that can lead to lifelong premature ejaculation. So now, acquired PE is something which is important and which is easy to treat. So most of the times there is some reason or underlying cause in acquired PE, because they were ejaculating normally before and then they are having premature ejaculation later. And this can be because of this can be psychological, sometimes this can be hormonal, sometimes this can be related to infections like prostatitis or seminal vasculitis. Sometimes even issues like uh, uh, melanoposthitis, sensitivity in the glans penis, phimosis, and tight frenulum, all these things can cause a premature ejaculation. So now coming to treatment of premature ejaculation, first thing is to try to treat the underlying cause. And majority patients, underlying cause is either local cause in the sense melanoposthitis or sensitivity in the glans penis, or sometimes initially it may be normal, but because of recurrent melanoposthitis or recurrent fungal infections, the penile gland skin may become sensitive, and because of this, it can lead to premature ejaculation. Sometimes just giving them proper lubrication itself will avoid premature ejaculation in those patients. And if the cause is infection, then we have to treat the infection. In my practice, at least 30 to 40% of premature ejaculation patients, they either have chronic prostatitis or seminal vasculitis, and which has to be treated before giving actual medication for premature ejaculation. Sometimes if they need circumcision because of recurrent melanoposthitis, it has to be done. Sometimes tight frenulum also has to be treated. Frenuloplasty has to be done before putting them on medications. As I said, sometimes even simple lubrication gel can also help them in premature ejaculation. So now, after treating the underlying cause, then we have to go for pharmacological intervention. And then if they are having severe performance anxiety, then we have to give them behavioral therapy or counseling for premature ejaculation. So now coming to pharmacological intervention, we have topical anesthetics, tricyclic antidepressants, selective serotonin reuptake inhibitors, and phosphodiesterase inhibitors. So now topical anesthetics, even simple lidocaine gel, 2% lidocaine gel can be given for premature ejaculation. But we have to ask the patient to apply this gel at least 20 to 30 minutes before intercourse. And if possible, they have to wash it off after 5 to 10 minutes of application. Otherwise, even patient's partner also feel that numbness, and this makes their sexual intercourse uncomfortable. So coming to medical management, we have tricyclic antidepressants, selective SSRIs, and PDE5 inhibitors. This is about now even topical anesthetics. We have it in gel form, spray form. There are various companies which are producing sprays now. Even sprays have to be applied at least 20 to 30 minutes before intercourse. So coming to tricyclic antidepressants, we have clomipramine, and we have SSRIs. SSRIs, we have paroxetine, fluoxetine, depoxetine, and each has different usages and different doses. and paroxetine and fluoxetine can be given on daily doses. But depoxetine is an on-demand drug, like how we give sildenafil. So I'll be dealing about all these things, what dosage we have to give, whether to give with PDE5 inhibitors in my later slides. So pharmacotherapy, these are the dosages what we generally give. Daily intake, paroxetine 10 to 20 milligrams. If it is sertraline, it is 50 to 100 milligrams. Cyclopram, fluoxetine. On demand, generally we give depoxetine and clomipramine. So now it's, if I start telling about that, before I start telling about the drugs, I will try to explain this in some case scenarios so that it's easy for you to understand in which case scenario we have to give which drug. So now coming to first case scenario, here we have a 24-year-old unmarried male. What is important is unmarried male complains of premature ejaculation. And whenever unmarried male comes to us with premature ejaculation, we have to ask them whether this is with masturbation or intercourse. Sometimes if it is with masturbation, if they say with masturbation, I generally ask them whether they masturbate by watching porn or they masturbate without watching porn. Sometimes if they are masturbating with while watching porn, sometimes if they do it without viewing porn, that itself will delay their ejaculation because of too much of excitement. And if it is both with masturbation and intercourse, and then it is a genuine cause, we have to treat it. But in this case scenario, where there is an unmarried male coming to us with premature ejaculation, first thing we have to ask them is whether he is having a regular partner or occasional partner. Why we say whether he has why we have to ask this is, now if we don't have a regular partner, occasional intercourse or intercourse once in 15 days or once in a month can lead to too much of excitement. Even that excitement itself can lead to premature ejaculation. So if it is because of too much excitement, only one way to ask them is if they try second time on the same day, whether they have premature ejaculation or not. Sometimes patient says, doctor, when I try second time on the same day, I get normal timing. That means they get good time to ejaculate. That means it's only because of too much of excitement. So simple SSRI or basic SSRI like fluoxetine will help in these patients. So now whether to put them on daily doses or long-term doses, that is again we have to decide depending on the need of the patient. Since the patient is not having a regular partner, since he is unmarried, we are not supposed to put him on long-term SSRIs or daily doses of SSRIs. But what happens is, why I say this is, even if you put them on long-term SSRIs, the moment he stops and if he tries to have intercourse after some time, after a couple of months, again, because of too much of either because of performance anxiety or too much of excitement, he can have premature ejaculation. So these people, they need proper counseling. We have to tell them that premature ejaculation is related with anxiety. This can't be cured completely when there is no regular partner or when there is no frequent intercourse. So we have to tell them we will give him some medications to control premature ejaculation. But in spite of these medications, whenever he try to have intercourse with long gap, he may have premature ejaculation. So this counseling will boost his morale. Otherwise, if you don't counsel them properly, he will think that most of these medications, whenever he takes medications, he'll be okay. And whenever he is not taking medication, again, he's getting premature ejaculation. So this will bring down his confidence and he thinks that lifelong he should be on medications. So we have to counsel them properly about premature ejaculation and why it happens. And in my way of counseling is, I'll tell them it can't be treated permanently before marriage. Only way to treat is after marriage. Once they start having a regular intercourse with their wife, that boosts their confidence. Because of the confidence itself will avoid premature ejaculation. That is the time I put them on daily doses of either SSRIs or TCAs. So now, second thing is I will ask them to avoid porn while masturbating. And third one, if they are having intercourse once in 15 days or once in occasionally, if they are having intercourse, another suggestion what we give them is to masturbate a couple of hours before having intercourse, so that that excitement will come down, so that second intercourse will give them enough timing. So now, how we treat them is we put them on either fluoxetine 20 milligrams daily doses or on-demand depoxetine on the day of intercourse. And we have to rule out tight foreskin, phimosis, and sensitive glands in these patients. And if there is sensitive glands, then we have to put them on lignocaine gel. We have to ask them before having intercourse. Coming to second case scenario, recently married, 27 years old male, complains of premature ejaculation, and wife is not happy. So this is the scenario where what we see commonly, most of the gynecologists, they see this kind of cases regularly. So now they don't want temporary medications. Most of this set of patients, they want cure, or they want to cure their problem, and they don't want to depend on medications. So first thing in these patients is you have to rule out prostatitis or seminal vasculitis or melanoprostatitis or tight frenulum. And the proper genital examination will rule out sensitive glands or tight foreskin. And if there is sensitive glands, either we can suggest circumcision surgery or topical anesthesia will help. But if they don't want to use topical anesthesia for on daily dose, then we can suggest circumcision for them. And if it is chronic prostatitis or seminal vasculitis, the way to identify this is a proper semen culture and transrectal ultrasound will rule out these things. Sometimes semen culture may be negative, but there can be chronic prostatitis or seminal vasculitis. So semen culture itself cannot rule out seminal infection. So sometimes semen culture may be negative, but their transrectal ultrasound shows chronic prostatitis or seminal vasculitis. There we have to put them on long-term low-dose antibiotics. We have to treat it first, and then we have to start them on medical medicine. So now, generally what we do is we either give paroxetine 10 milligrams or 20 milligrams. Generally, we start with 10 milligrams and slowly we will increase it to 20 milligrams along with tadalafil. Because these males already, since they are married and they already they are having multiple failures because of performance anxiety, without adding tadalafil will not help them. So you have to, even though they are not having erectile dysfunction, we have to put them on either 2.5 milligrams or 5.5 milligrams of tadalafil on daily doses. And on demand, initially we'll ask them to take on demand depoxetine with or without 10 milligrams of tadalafil. After a couple of normal intercourse, that means once they think that there is no premature ejaculation with these drugs, then we'll ask them to stop depoxetine and try only with paroxetine and tadalafil 5 mg. And after some time, slowly we'll withdraw these drugs. Even if there is no response, then we can try sertraline 25 milligrams or 50 milligrams. So coming to third case scenario, we have 48 years old male patient who is complaining of premature ejaculation since 3 years. And he also says occasional erectile dysfunction. So now this is a case of secondary or acquired premature ejaculation. So now how to treat is, first thing is we have to ask them what is their sexual frequency. If they say their sexual frequency is once in a day or once in alternate days, then we have to treat them in a different way. If they say their sexual frequency is once in a week or once in 2 weeks, then we can put them on on-demand medications instead of giving them daily medications. So they need these people, since he's already around 48 years, we have to check for his hormones. Generally, what we do is we do prolactin, testosterone, and thyroid, and we have to rule out infections in them. Seminal culture and transrectal ultrasound will help in ruling out prostatitis or seminal vasculitis. And if their sexual frequency is occasional, then on-demand medication is enough for them. Either tadalafil or sildenafil with depoxytin 30 milligrams combination. And if their frequency is more, then we have to treat it like others. Then we put them on daily doses of 5 milligrams tadalafil with paroxetine. That should help him. And maximum dosage of depoxytin is around 60 milligrams. Even with 30 milligrams, majority of these patients will have side effects like nausea, vomiting, bowel disturbances, watery stools. All these are the sometimes headache. All these are possible side effects of depoxytin. So now, okay. So now, to summarize, patients with premature ejaculation alone, I told we have discussed what to give. We can actually start with fluoxetine 10 milligrams, 20 milligrams, or paroxetine 10 milligrams daily and daily doses, with or without depoxytin on-demand medication. But most of the males, if they are having performance anxiety, or if it is associated with erectile dysfunction, and these are the possible combinations we can use. Sometimes sildenafil alone, either 50 milligrams or 100 milligrams alone, is enough to treat premature ejaculation. So the people who are having only performance anxiety, for them only giving sildenafil citrate 50 or 100 milligrams as on-demand drug will help for both premature ejaculation and erectile dysfunction. In some patients, we have to give tadalafil 30 milligrams and depoxytin 30 milligrams. If they are not responding, then we can increase the doses of tadalafil to 20 milligrams. If they are having severe erectile dysfunction, then we have to give them 20 milligrams of tadalafil with 30 milligrams of depoxytin. But if patient says he's not happy with tadalafil and he is getting better erections with sildenafil, then you can give either sildenafil 50 milligrams or 100 milligrams with depoxytin 30 milligrams. And this has to be given, all these on-demand medications have to be given at least 60 to 90 minutes before intercourse. But these medications should not be taken on daily doses. Alternate days or twice in a week should be okay, but not on daily doses. But if they want frequent, if their sexual frequency is very like on daily basis, then we can't give them sildenafil and daily doses. That is where we have to give this low dose tadalafil and SSRIs. Here, generally, we start with tadalafil 2.5 milligrams and 5 milligrams of tadalafil and fluoxetine on daily doses. If they are not responding, next month we'll change it to we'll stop fluoxetine and we'll put them on paroxetine 10 milligrams. But only thing is paroxetine, they say now at least in some set of patients, in around less than 0.5 percentage patients, there are suicidal tendencies. But I haven't seen any patient who has complained about suicidal tendency after paroxetine. 0.3% is very low according to me. But generally we don't give paroxetine on higher doses for premature ejaculation. Most of my patients, they respond with 10 milligrams of paroxetine, and generally I stop paroxetine after 2 to 3 months of therapy. And if they respond well, then I convert it to fluoxetine. If they need some medication for long term, then I'll initially 1 or 2 months I'll give paroxetine, and later I'll change it to fluoxetine. So coming to the I think this ends our premature ejaculation lecture. But Dr. Apurva said he asked me to cover low libido in men also. So now coming to men who are having low libido, sometimes your patient may say that their husband is not interested in intercourse and they are not showing any intercourse, and this is a very common scenario in our practice. And when we ask their sexual frequency, they say once in a month or once in 2 months. Uh, in general, we see patients who are having intercourse once in 2-3 months after their marriage. And yesterday, I've seen a patient in 7 years, he had intercourse only for 10 times. So what is the reason for low libido in men? So now these are the possible reasons for low libido. One is psychological. In psychological, this is the major factor in most of the males who has low libido. Basically, this is because of performance anxiety. Performance anxiety, the moment he feels that he may not complete the sexual act, or if he thinks that he is having sexual erectile dysfunction, or if he is having a premature ejaculation, and once he thinks that his wife may not be happy because of premature ejaculation, or sometimes during intercourse, if wife or partner comments on his sexual performance, then they stop trying for intercourse. That is the one of the major reason for low libido in men. Generally, it's not low libido. They stop their sexual intercourse to avoid embarrassment. So now these patients have to be counseled properly, and unless we ask them the history, unless we send the female partner outside, we talk to the male alone, then only they'll come out. When they sit as a couple, most of the times these males generally they don't open their mouth and they just say, "I don't have desire." But most, if you carefully counsel them, then most of these males will open up and then they will tell us the probable reason for their low libido. And some males, they find pleasure in masturbation because there is no failure in masturbation. Even though they are not getting an erection, they can masturbate even without erection, and they ejaculate. So they don't find any major uh, issue with masturbation. So instead of having sex, they start masturbating on a daily basis. So the people, most of the males who come to us with low libido, are when their partner says their husband is having very low libido. When we ask them, most of the males, they say they masturbate on daily basis. So that should be that is the reason we have to carefully counsel these patients. And other reasons for low libido in men is vitamin deficiency. Nowadays, vitamin D and vitamin B12 deficiencies, patients, they have very low libido. And even people with low testosterone and hypothyroidism, uh, and people and even people with low and high estrogen, we have found that their libido is on the lower side. And low estrogen, generally, I saw people complaining of low libido after giving letrozole or anastrozole. So initially, when we start letrozole or anastrozole, they'll be happy because their testosterone increases. But after some time, they come back saying that, "Doctor, my nowadays my erections have gone down. I'm not feeling like having intercourse." So that is the time when I check their hormones. Their testosterone levels are normal, but their estrogen levels are very low because of our letrozole tablet. So that is the reason nowadays I stopped using letrozole on regular basis. Nowadays, either I give weekly twice or once in a week. Otherwise, daily doses of letrozole or anastrozole should be avoided. And people with high estrogen, low testosterone and high estrogen also, they have low libido. And apart from this, see, these first four things are easily treatable causes of low libido in men. And there is one more thing called hypoactive sexual desire disorder. This is again it's both males and females, and this is like a genital thing, a genetic thing. Most of them, they are born like this, and whatever medications we put them on, they don't improve. Their desire levels are very low. Thank you. I think I have covered most of the issues, practical
Yes, sir,
issues in premature ejaculation.
yes, sir, it was a very fantastic and mind-blowing talk. Apurva, are you there?
Yes, sir.
Yeah, yeah.
Sir, before I want to take note from sir, I think Madhuri Patel ma'am is there.
Okay, okay. Just, yeah.
Madhuri ma'am? Yeah. Ma'am is there. Yes. I welcome Dr. Madhuri Patel ma'am. Again, ma'am doesn't need any introduction. Ma'am is the first female Secretary General of and I invite you for your blessings and for your kind words. Madhuri ma'am?
Madam, you have to unmute.
Can you hear me?
Yes, ma'am. Yes, ma'am. You are audible.
Yes,
Yes,
yes.
yeah, ma'am. Yes, ma'am. Please.
Raj, thank you very much. I'm very sorry, Dr. Reddy, that I could join only after your talk. But today's talk was very, very important. Premature ejaculation, and we know that 20 to 30% of the men suffers from it, and it really causes stressful condition, not only in the men but also in their wives, and they are emotionally upset. We see majority of the patient in infertility group, they come to us, they are very shy, their marriage life is at the stake, and they are really, really upset about it. Some of the wives understand the problem, but some of the wives, they don't understand. So I was not there. I'm sorry, Dr. Reddy, but I would have loved to hear. I will definitely hear the video. And Neeraj and doing the great work. I think Neeraj last month of his tenure as a committee chair of the sexual medicine, and he has done a fantastic work. He's got his prize also, award also for the same, and I hope Apurva will continue the same. And I thank Dr. Rishikesh and Asha Bakshi and entire team for giving me this opportunity. Thank you, everybody.
Thank you, madam.
Thank you.
Thank you so much, ma'am. Even in your so much busy schedule, you are always there for your blessings, for your guidance. And I just want to share everyone that this Zoom platform is provided by the Foxy, and it is the initiative of Madhuri ma'am only. That the Zoom is provided by the Foxy office, and we are using this Zoom, and so that we are able to conduct this type of webinars for all of us. So thank you
So
so much, ma'am, for always
let me
being there.
share with you, when Neeraj talked to me, madam, nobody is sponsoring our program. So I said, okay, we will give you Zoom, platform. And Neeraj has done fantastic work. He has spread the awareness, the sensitize our members, and plus also the community. So Neeraj, I am really congratulating you and appreciating you for doing the excellent work. You have utilized this platform at the right way, and I'm really happy. And Apurva, you can also continue on this platform because still I'm 1 year there with you all. So thank you once again.
Thank you so much, ma'am. Thank you so much, ma'am.
Thank you, madam.
Thank you. Sir, about Rahul sir, thank you so much, sir. Your lectures is always to the point. Just we want to say, ये just मछली की आंख जैसा होता है. Like Arjun is always hit on the eye of the fish. It's all like that. We all get a lots of very practical tips from your your lectures. So thank you so much, sir, for always being here. Thank you, sir.
Welcome.
Sir, I want to just ask one thing. Can you hear?
Yes, sir. Yes, sir.
Yeah. Is there any role of the squeeze technique or start and stop technique? Is there any role in clinical practice, or it is just theoretical?
Only people with performance anxiety or pure psychological, psychogenic premature ejaculation, it helps. So when nothing was there, when no medication was available, that is the only way for us to treat. But there is nothing wrong in trying.
And sir, I just also want to know, what about the Kegel exercise in male? Does it work, sir?
Yeah, definitely it works. See, Kegel's exercise, even with people with pelvic floor, loose pelvic floor or relaxed pelvic floor, or even in patients with chronic prostatitis, Kegel's exercise have a role. That is why we ask all our patients to do Kegel exercises, whether they are on medications or not on medications. We ask them to do Kegel's exercise.
Okay, sir. And
And
secondly,
yes, sir,
this.
one more thing. Apurva, one more
Yes,
thing.
yes, sir.
Is there any role of HIFU, high intensity ultrasound, focused ultrasound?
Basically, it's not HIFU, sir. It's low intensity shockwave therapy, sir. Basically,
No.
the same shockwave therapy what we use for low erectile dysfunction, it comes with a different arm or different frequency where we can focus the prostate. Basically, this works only in patients with chronic prostatitis, not for normal premature ejaculation. People with psychogenic premature ejaculation or penile related issues like sensitive glands or phimosis, it won't help them. Only in patients with infections which are leading to prostate infections leading to premature ejaculation, this shockwave therapy will work.
No,
And
sir.
we have seen very good results.
Yes, that's right. But this aesthetic gynec or cosmetic gynec people are advocating this chair. There is a chair in HIFU,
Yes.
and they advocate
Yes.
as a pelvic floor exercise. So,
Yes.
what do you say about that?
No, actually, one of the local gynecologists, she bought that mission, and I've seen that, sir. And we are planning to use that for at least for 10 patients. We got permission from
Okay.
her. Probably from
Okay.
January 1st, I will do at least for 10 patients and then I will cut back. I've seen
Okay.
that mission. Practically, I have, see, basically, it's a different form of Kegel's exercises.
Yes.
Yes,
Sir,
yes.
sir, that is that MCELA chair is actually using that low intensity vibration, what sir is telling. And actually, I have using this in one of the few patients, because luckily in a demonstration in my city, it was kept that you can use for that. And I think it has probably the psychological role or probably the Kegels, but the patient do get some good results after using that.
Yes.
But definitely, I think, sir, it's a very costly effort, and the chair is actually very costly.
Yes, yes.
That is the thing.
No, instead of that, the basic low dose shockwave therapy is more cost effective.
Yes, sir. Absolutely. Absolutely, sir. Absolutely, sir. So that is the thing. I think there is no more questions.
Now, there is one question. What is treatment of for premature ejaculation with low sperm count? Are there any drugs to be avoided? Basically, all these SSRIs can decrease sperm count, sperm production. So, and paroxetine, I have seen practically that by giving paroxetine in infertility patients who are taking treatment, the semen counts and quality has gone down. So nowadays, if an infertile male, if he asks me to start treatment, generally I put them on only local anesthetic gels. I will tell them that all these medications will have side effect. So I'll treat them for their infertility first, and later I will treat for premature ejaculation. But fluoxetine slightly has better safety compared to paroxetine, and depoxetine, on-demand depoxetine is also safe for this in infertile people.
Okay. Okay, sir. Neeraj, sir?
Yes.
Yeah. Should we
Yeah.
conclude, sir?
No, let me say my final. This is my official.
May I share my thoughts, sir? Dr. Apurva?
Yes, sir. Yes, sir. Yes, sir. Yes.
Sure, sir. Samsul, sir. Absolutely,
Okay,
sir.
thank you. It was a nice presentation by Dr. Rahul Reddy. Thanks for a wonderful presentation. So basically, so far all the available drugs SSRI is the most effective drug in case of premature ejaculation, and paroxetine has got the highest IELT.
Side effects.
It increases the IELT at least 6 to 8 folds. Let's say somebody is coming out within 1 minute of premature ejaculation, 1 minute of penile intercourse. Using paroxetine from 10 to 40 milligram dose can increase the IELT, intravaginal ejaculatory latency time, up to 8 minutes. It increases 8 folds. But the problem is, if someone has got infertility, it has a DNA fragmentation rate more than 25%.
Okay.
So it has to be used cautiously during giving persons who are expecting infertility, expecting baby. PRP or other shockwave therapy has got more role on erectile dysfunction, less role on PE. Probably Dr. Rahul Reddy can elaborate more. But usually, so far, the recommended dose by ISSM is paroxetine. Though ISSM it's off-label in some countries, but it has got more superior role than dapagliflozin, because dapagliflozin doesn't stay in the blood for more than 5 hours. So paroxetine is there if someone has got performance anxiety. If you provide them paroxetine daily dose, it has a significant improvement. And my friend Dr. Ege Kanserifoglu from Turkey, he has applied Botox, and it was under trial, and they showed that it increases the latency time, the second phase of ejaculation, that is the expulsion phase. They lengthen the time. So Botox has some role as well. But these all are doubtful. But so far, all the medications we have, paroxetine and tricyclic antidepressant clomipramine has got the highest ILT. And like Dr. Rahul Reddy has said, that for someone who has got the penile hypersensitivity, then the local anesthetic has a very good role. Thank you. Sorry for taking time.
Thank you, sir. Apurva?
Ji sir. Sir, yes,
Yeah,
sir.
yeah.
Please, sir.
Yes. So, is there any question, or we are finishing?
No, I think in
No
the
more
chat
question,
box,
no?
no, sir,
Okay.
there is no question in
Okay.
the chat box. Yeah.
Okay. So, it's a little bit emotional moment for me, because this is the last webinar under my chairmanship for Sexual Medicine Committee. But with Apurva there, I'm sure we will continue all the activities we are doing since last 4 years. So hopefully we will do with more vigor and with more passion. We will continue this activity about the academic, as well as we know about the public awareness and about the sex education. Also, we want to, as we have discussed, okay, we will do something more positively in the next year. So in ASU Hyderabad, there will be our workshop. I hope many people will who are coming to the ASUOG will attend our sexual medicine workshop. And with that note, I thank everyone, all my 3-year president, my vice president, all my committee member, all and especially Apurva. Apurva is like my right hand. Without him, I because when you are not there up to 6 p.m., I was little bit panicked. Where is you? So he is my right hand, and without him, I just got stuck. So thank you, Apurva, for being there and being all the help in the everything we have done in last 4 years. So thank you. Apurva, over to you.
Doctor.
Yes, Dipali. What of thanks?
Sir, so first of all,
Yes,
I just
yes,
before
Apurva.
ending, sir, I just wanted
Yes.
to say something. Sir, you are still our chairperson, and sir, I am doing it. There is no difference from me before when we
Yes.
started. So I feel like it is the same thing. It is the continuation of the same thing.
Yeah, we will continue.
So you are always be there, sir. And every program without your blessings is really, sir, it's not possible for us. So thank you so much, sir, thank you is just I don't have any words to say you, sir. You make this committee so vibrant. And people doesn't know about this committee because when I started doing programs with the different societies, people are actually asking me, is there any committee known as the sexual medicine committee? Is it is exist? Somebody once, a doctor asking me, one of the president of the society asking me, is a new committee formed in 2020 in Alpesh sir's tenure? These were the words. So, sir, you make this committee the most talkable among the all the Foxy society. Sir, it's you, and it's really what Mitra ma'am has told me now. It's a really a very challenging to me to meet your expectations and the meet your to maintain those programs which you have started. So I really always need your blessings, sir. And whatever we know about the sexual medicine, it's all due to you, sir. So you will be always be our chairperson, the super chairperson, sir. Thank you so
I,
much,
I,
sir.
I am always there, and it's always about the teamwork. Without teamwork, you can't do anything.
Thank you, thank you so much, thank you so much, sir. Thank you, sir. So Dipali ma'am, yeah.
Yes. I would begin. I would like to begin the vote of thanks by thanking President Foxy, Dr. Rishikesh Paisa, under whose able leadership our society is progressing by leaps and bounds. I would also like to thank Secretary General Dr. Madhuri Patel ma'am for her guidance, and also Dr. Asha Bakshi ma'am, Vice President West Zone Foxy, who could not be here today, for her guidance and support. I would also like to extend heartfelt thanks to Dr. Neeraj Jadhav, sir, chairperson, for conceiving and implementing Practicum series and for making us, the routine gynecologists, more learned in the topics which are not discussed in regular conferences and meetings. I would also like to thank our guest of honor, Dr. Mitra Saxena ma'am and Dr. Anita Sabarwal ma'am, for sparing time from the busy schedule. I would like to congratulate and thank Dr. Rahul Reddy, sir, for his brilliant deliberations, sir. Thank you so much, sir. I would also like to thank our upcoming chairperson, Sexual Medicine Committee, Dr. Apurva, for his support and guidance. Last but not the least, I would like to thank all the attendees for joining the session today. Thank you all. Thank you, sir.
And thanks to medicine people who are telecasting this webinar on their app, that is a Medisage app.
Medicine. Thank you.
We are thankful to ICOG chairperson as well as ICOG secretary for granting us the one ICOG credit point.
Thank you.
Thank you. Thank you. Thank you. Thank you so much. Thank you so much.
Thank you.
Thank you, sir.
Bye-bye, sir.
Bye, sir. Enjoy, sir.
Yeah.
Bye.
Bye.
Bye, everyone.
Bye.
Bye, everyone.
Bye,
Thank
sir.
you, sir.
Thank you, sir. Thank you, Rahul, sir. Thank you, sir. We'll catch you.
Welcome.
Thank you, Jadhav, sir, Apurva, Dr. Rahul. Thank you, sir.
Apurva. Hello. Hello.
Let me see.